talking to you all, and there is no other venue to make this presentation than KREST, where we started all the education. Subbarao Garu was the primary reason that myself and most of us have gotten into radiology, and we do what we do today in sharing our knowledge, education, and trying to make things better in our own way. It's also an honor to be with Professor Matsudan Rao Garu. He's right here with me, and he is a father and mentor to me. And I'm in the very house and the very basement in Matsudan Rao Garu's house, where I started my radiology training and residency here. So I think it's a double honor for me to be here and to be giving this talk. So
okay, it's like sun coming home for us. Sri and Vamsi are like our children. So today our children are visiting us, and it's a great honor actually to for all of us that he is giving this presentation from our house.
Thank you. Thank you. So let's go ahead and get started here. Okay. Are you all able to see the presentation? The slide presentation?
Yes, yes, yes.
Okay, great. And you can hear me okay?
Yes.
Okay, fantastic. Let's get started. So today it's I'm going to talk about a case-based review of hepatobiliary MRI, and liver MR is an area of interest to me, and that's where I spent a lot of time. We are one of the pioneer liver transplant programs, so we have a lot of liver cases that we see, and this is one of the services I helped build as I started my career at WashU, and helped set up a transplant program and also start a transplant disciplinary conference. We started in 2004, and we discussed various cases. So, all right. So a few acknowledgements here. I have no relevant financial disclosures for this presentation. Acknowledgements, I do owe it to some of my colleagues for sharing some of the cases with me. All of them, even though they are at different institutions, they're all part of Mallinckrodt, and they moved on to at Mayo Clinic or UCSD. Of course, Anup is the current director for MR. He is with the Mallinckrodt with us right now. So the objective for this talk is to review some of the most common biliary lesions and MR imaging features that will help us make a specific diagnosis. This is by no means a comprehensive lecture. I'm not covering all the lesions. As a matter of fact, I'm not going to spend much time on hepatocellular carcinoma or hepatic adenoma, some of the common lesions, but I want to share with you some of the different lesions that we come across and the common benign lesions that we have to make a diagnosis, and not just simply state that there is a lesion in the liver. Our role as an MR imager is to make a specific diagnosis or a definitive diagnosis as much as possible so that we can guide our clinical colleagues as to what to do. So let's start with this. So here is a case where the patient, there's an ultrasound image. You can see an hyperechoic lesion. You go on to a T2 weighted MRI. You see the lesion is slightly hyperintense on T2. And then going on to the gradient echo in phase and out of phase images, you see the lesion drops out, or this focal area drops out signal on the out of phase images. This is, as you all know, it's a very classic focal fat deposition, right? Now, I want to take a minute here to go over some of the basic fundamental principles. Notice that when you look at on the T1 weighted images, when you compare between in phase and out of phase, the liver is slightly hyperintense or brighter on the out of phase images. This is how you would like to set the sequences up, meaning that when you have multiple echoes that you get out of phase images that are possible, for example, at a 1.5 Tesla, you have 2.1 milliseconds for out of phase, 4.2 for in phase, and again, add 2.1, you'll get out of phase and so on. You want to acquire your out of phase images at the shortest possible TE, and your in phase should be after the out of phase sequence. That's how you need to set it up, because you want to account for the T2 star decay that's going to take place anyway as your TE goes up. So the main point here is that your TE on the out of phase image should always be shorter than the in phase image that you're using for liver imaging there. All right. So here are the T2 weighted images on the left and the T1 weighted images on the right. If you look at the signal intensity of these on these images, and if you compare, CSF is the most bright on T2 weighted sequences, right? When you compare the signal intensity of the CSF to spleen, the spleen is less intense than the CSF. Kidney is very close to the spleen. And then if you look at the liver, liver becomes darker than the spleen and the kidney, and the pancreas typically is the darkest. Depending on how much your TE value is, this typically is the darkest. So this is how the signal intensity is on any T2 weighted sequence. If you go to a T1 weighted sequence, it becomes exactly the opposite. The pancreas becomes the most hyperintense or brighter on T1 weighted images, which is exaggerated when you do a fat saturation sequence or fat sat pulse. And then you have the liver is slightly less bright than the pancreas, and then the kidney is less bright than the liver, and the spleen is similar to the kidney, and then the CSF is the darkest. This sounds simple, but this is very, very important to understand this and recognize this signal characteristics, because you are going to use these signal characteristics to help you identify the presence or absence of a lesion, or versus a benign portion of the liver versus a malignant portion of the liver. Also to remember is that on any sequence, your liver almost always parallels the signal intensity of the skeletal muscle. Okay, so that's going to be an important thing, is that I'm going to probably use a laser pointer here. Okay, the liver parallels the signal intensity of the skeletal muscle. So that is the key in terms of recognizing that any sequence that is given to you, that the liver should parallel the skeletal muscle signal intensity. This is more so for our junior residents or junior faculty. Now look at this post-contrast image. This is a post-contrast image. You see the entire right hemi liver has this heterogeneous appearance, and it looks like a very ominous lesion that is almost involving one half of the liver. If you start looking carefully, you see the blood vessels are still coursing through this area of abdominality. This patient initially had a CT and came to an MRI with a diagnosis of hepatic infarction. So when you go on to the chemical shift out of phase images pre-contrast, you see again, there is a hypointense area involving the right hemi liver. It's only when you see the in-phase images, it becomes very clear that this is all fat deposition. This is an extreme case of fat deposition, but you have to recognize that it can look very scary. It can look like it's an area of infarction. And having the T1 and T2 weighted images is very, very important, as is the in-phase and out-of-phase images. You have to also keep in mind that any lesion, any mass lesion that is there, a space-occupying lesion, should have hypointense signal intensity on your T1 weighted images. So on in-phase images, you should see it as a space-occupying lesion as hypointense. The moment you don't see it, then it tells one of two things. You're dealing with something very close to the liver, or it could be hepatocytes in terms of having that signal intensity that you're taking into account. Another example here. This is an in-phase on the top and out-of-phase images at the bottom. You see these areas which are dropping out in signal. So you see right away there is some fat deposition. But this is a pattern of fat deposition, particularly when they were doing islet cell transplants. They were doing islet cell injections into the portal vein. You'll see this peripheral accumulation of fat within the liver parenchyma. If you look closely, the liver is slightly darker than the skeletal muscle. So this patient actually has iron deposition within the liver. Anytime you suspect iron, we now routinely do iron quantification as well. We acquire a sequence for iron quantification. When clinically it's required, we go back and quantify it. Is you want to get multi-echo T1 weighted images. You get few slices, you get them at the lowest possible TE, typically 2.1 milliseconds, and you keep upping the TE and go up to 15, 16, or 17 milliseconds, so you can see the exponential loss of signal in the liver if it contains iron. All right, let's shift gears a little bit into a few cases where we, let's go through this. So here is a 25-week pregnant woman presenting to the emergency room with right upper quadrant pain. So take a look at this. On the top left coronal, you have a coronal haste or a single shot fast spin echo sequence. You have an in-phase sequence right here, and you have an out of and the T2 weighted sequence right here. So what is the most likely diagnosis? Is this a ruptured adenoma? Is it a ruptured hemangioma? Is it a hepatic abscess? Or is focal nodal hyperplasia or hepatocellular carcinoma? I will let you, I know this is not a quiz, but I would want you to take a moment and think for yourself and commit to a diagnosis. You don't have to say it out, but commit yourself to a diagnosis of what you think it is. Then I'll share with you what it is and why it is. So we had a debate when this patient came up. Half of us said that this is a hemangioma that has ruptured or had hemorrhage into it, and others felt that this is hepatic adenoma. Just because she's a young woman, adenomas are more common. If you take a step back and look at it, this is brightness and T1. That is telling us there is some hemorrhage into this lesion, right? There's a lesion, there's hemorrhage into the lesion, and that is darker on T2. But look at the background signal intensity of the lesion. This is very hyperintense, homogeneously hyperintense. And then, so if you didn't have this hemorrhage, you would think that this is a hemangioma. As a matter of fact, this patient did go on to have delivered the baby and came back postpartum to have a CT. And then we can see it's a classic hemangioma, as a matter of fact, but this hemangioma bled. I want to emphasize this particularly with hemangiomas. Hemangiomas are the most common benign lesions that we encounter. But at the same time, this is the most commonly misdiagnosed lesion that we encounter is also hemangioma when we fail to recognize the various patterns of hemangiomas or atypical nature of hemangioma. So our role as radiologists does not stop just to say, yes, there is a large lesion in the liver, but we are doing a disservice, particularly with an MR, unless we go into specific characterization, and if we can characterize this with certainty as much as possible. So cavernous hemangiomas can have spontaneous rupture or hemorrhage. It's only a small percentage that do that hemorrhage, and then 1 to 4% of them. But it's important to remember that, especially if the hemangioma is subcapsular, a patient may have hemorrhage into the peritoneal cavity, which can be lethal in some of these patients. But fortunately, that's rare. All right, let's look at this example. So here is a T2 weighted sequence, nice bright T2. I typically call this as a ground glassy, hyperintense T2 appearance. And then if you look at the post-contrast, peripheral nodular enhancement and progressive enhancement and filling of the lesion. Very, very characteristic for hemangioma, right? But notice that you should never see a washout of an area that enhances for hemangioma. So an area that enhances with hemangioma, it can become iso-intense to the background liver, but should never, ever become hypo-intense to the background liver. So that's a very key observation that you're going to make, because that will help you differentiate hemangioma from other lesions. So here is another example, a lesion that enhances right away in the arterial phase, but does not wash out. So it retains the contrast, unlike a arterially enhancing metastasis or another primary lesion, which would have washed out into the equilibrium phase. You don't see a washout. So this is indeed a hemangioma. They also called the type 1 pattern of enhancement. It is not uncommon to see this transient hepatic intensity difference along or wedge shaped of areas of enhancement adjacent to this hemangioma. So that should not throw you off. That still is a hemangioma. But notice that there is no washout whatsoever, either in the center or in the periphery of the lesion, the area that enhances. Very, very characteristic for hemangioma. Here is an example of giant hemangiomas. Look at the very large lesions. Whenever you have giant hemangiomas, you can have a central scar. And then the key thing here is that look at the mass and the mass effect this has, but still there is no biliary ductal dilatation. Very, very characteristic for hemangioma. There's no reason for these lesions. None of these lesions, you should send the patient for a biopsy. You should be able to make the diagnosis in all these particular cases without giving a differential. You should be able to say that this is indeed a hemangioma. Here is a T2 weighted sequence, and you see on the post-contrast arterial phase images, there is a rim of enhancement there. It's a kind of a concentric rim. It is struggling to enhance and fill up over time. It doesn't really fill up over time. But one thing it is pointing towards benignity is the fact that there is no washout of the areas that have already enhanced. So this patient has what is called a sclerosing hemangioma. If you see a lot of hemangiomas, you'll come across enough that you will come across sclerosing hemangiomas. This is in contrast to cholangiocarcinoma, which I'm going to share with you later on. But notice the rim of enhancement is peripheral and it fails to enhance into the center of the lesion. Another example of extensive hemangiomatosis, the point I want to make is that even when the liver, we have had a handful of patients who had to get a liver transplant because of extensive hemangiomatosis and not leaving any normal liver for function. As a result, they had to get transplant. But even in these patients, you will not see biliary ductal dilatation or obstruction. This is not Bildil. This is just a scar in the hemangioma. So the point to note is that even with extensive hemangiomatosis, you will not see biliary ductal dilatation. The moment you see that, you are not dealing with hemangioma, you have to think about something else. Okay. A word of caution or just a reminder, we all use the hepatobiliary contrast agents, right? Like the multi-hands where we do 1 hour delayed images and the EOVist contrast that we do 20-minute delayed images where there's excretion of the contrast into the biliary ductal system. This is a classic hemangioma. But if you have a very classic hemangioma, if you use hepatobiliary contrast agent, you may not have enough of time to fill the lesion and for the lesion to have the take up the entire contrast. So you need to be aware of this fallacy that if you're using a biliary contrast agent, particularly the EOVist or contrast agents, which are excreted, 50% of which is excreted into the bile ducts, hemangiomas may not fill up. So just be aware of that as you make the diagnosis or evaluate these patients with MR. Okay. I'm sorry, I'm using the term EOVist. That's our trade name here. It is gadoxetate disodium. I'm not sure what the trade name in India is. So another example here, different case, 55-year-old female with incidentally detected lesion on ultrasound and underwent an MRI. So let's look at the T2. Here is a lesion that is hyperintense in T2. And then, yes, you could have a differential for hemangioma in the T2 here itself. And then look at the T1 pre-contrast, look at the post-contrast arterially, there is peripheral enhancement. Subsequently, there is progressive enhancement. And on the 5-minute delayed, you see the central area is enhanced and the periphery is washing out, right? So what is the most likely diagnosis here? Is it a hepatic adenoma? Is it a hemangioma? Is it a hepatic abscess? Is it a cholangiocarcinoma or hepatocellular carcinoma? Now, with this pattern of enhancement, again, I want you to commit. You don't have to tell me what you're thinking the answer is, but I want you to commit and then come back as we discuss, and we can see it. And if you have any questions, make note of it. I'll be happy to answer your questions towards the end of this. So this pattern of enhancement, peripheral enhancement, progressive central filling, even though the contrast is being retained on the delayed images, notice that there is a peripheral washout, right? And just to restate the term washout, if you see an area in the liver that becomes less intense than the background liver parenchyma on the subsequent post-contrast images like portal venous or equilibrium phase images, that's what we call it as washout. It's less intense than the background liver parenchyma, not in comparison to how the lesion behaved in the RTL phase. It is in comparison to how the background liver parenchyma is behaving. I'm sure you all know that, but just wanted to emphasize it. So this pattern of central enhancement and peripheral washout, it is not a hemangioma, period. So you should never, ever see a peripheral, any kind of washout whatsoever in a hemangioma. This is indeed a patient who has cholangiocarcinoma. It's a very characteristic appearance for cholangio. Over time, it accumulates. And I've seen many people include hemangioma in the differential. It should not even be in the differential when you see this pattern of enhancement. Okay. So the washout is very, very characteristic feature for malignancy. It doesn't tell you what malignancy it is. It could be a cholangio, it could be a hepatocellular carcinoma, it could be a metastasis, or any other malignant lesions like a neuroendocrine tumor, other malignant lesions that we come across. So just be mindful of seeing washout and as a sign of malignancy. Here are a few other examples. We are seeing here a classic adenocarcinoma metastasis. It doesn't tell you what kind of an adenocarcinoma, but the pattern of this enhancement is very typical for adenocarcinoma. Enhancement, peripheral washout, see that progressive central filling and washout. And the one on the left is a colorectal metastasis, and the one on the right here is from prostate metastasis. Prostate is also an adenocarcinoma. Rarely goes to the liver, but it can go to the liver and can behave similar to any kind of an adenocarcinoma. So, and here on this set of images in the bottom right-hand corner, hypointense lesion on T1 weighted images, there is an increased signal intensity on T1. So that's telling you there is either some fat or there is hemorrhage into the lesion. And then post-contrast, you see arterial enhancement, and the portal venous phase, you see this area that enhanced has become less intense than the background liver, and the central area that hemorrhage hasn't enhanced. This is indeed the patient who had underlying liver disease and a classic hepatocellular carcinoma. Okay, let's look at a few other examples. Here is a case where you have, let's look at the HASTE T2 here. You have a hyperintense or slightly hyperintense lesion in T2. It looks like the bile ducts are slightly dilating. If you remember what I said earlier on, is that you don't see biliary ductal dilatation with hemangiomas. So even though the T2 signal intensity looks like it could be hemangioma, it should be right off the bat, you should be questioning that, saying that, hey, I'm seeing bil-dil, and I should not be seeing a bil-dil on these patients. There is some background noise, please. If someone has it unmuted, so please, if you can mute your phone or your computer, that'll be great. So here is a diffusion weighted images. On the diffusion weighted images, you see that there is diffusion restriction. Pre-contrast and the T1 weighted post-contrast, you're seeing there is some early enhancement, and subsequently you see there's some progressive enhancement, and almost looks like the lesion is enhancing fully, but then again becomes hypointense later on. So there's one more observation here. These areas are subcapsular, and this abnormality is almost radiating towards the porta hepatis. If you can pick it up, and if you can, if that comes to mind, that these are coming subcaps that are going towards the porta hepatis, then you get the diagnosis. This is an epithelioid hemangioendothelioma of the liver. But the key point here is for you to recognize that this is not a benign lesion, this is a malignant lesion, and this is not a hemangioma. All right, let's look at this case. So T2 weighted sequence, hyperintense on T2, diffusion weighted imaging, the slight diffusion restriction as you see it on the ADC map, not very intensely diffusion restricting, very bright, light bulb bright on T2. Go on to the pre-contrast and the post-contrast, there's peripheral rim of enhancement, and you can see there is some enhancement and washout. So no matter what, irrespective of what the T2 signal intensity, this is not a hemangioma, and you have seen the washout. There's no way this will be a hemangioma. There's slight diffusion restriction that could go either way. This is an angiosarcoma of the liver. They're hyperintense on T2, they enhance intensely, and they can wash out, and they could even have a light bulb enhancement, but they will wash out. This is a malignant counterpart for hemangioma. Angiosarc is a malignant counterpart for hemangioma. We are fortunate that it is extremely rare, but again, a point to note is that the washout, whenever you see washout, is a sign of malignancy or not benignity. Little bit about hemangiomas and diffusion. You may be wondering, why am I spending so much time on hemangiomas? The reason I'm spending that is that this is by far the commonest lesion, and the most misdiagnosed lesion is hemangioma. So our role is to not only accurately diagnose hemangioma, but at the same time differentiate that with other malignant lesions. So we all do diffusion imaging now, right? So the question comes up is that if you're in a bind, if there is a diffusion restriction, am I dealing with hemangioma or is it a malignant lesion? You have to be very careful with that. In general, if you look at this scatter plot, the hemangiomas, the spread of diffusion restriction on hemangiomas, it goes from somewhere around 1.2, 1.3, which is at the lower end or the higher end for malignancy, to much higher numbers in terms of the ADC values. So there is a spread for hemangiomas. So our observation is that if you have atypical hemangioma, meaning that the lesion is not characteristically enhancing, it's going to enhance slowly over time, those are the lesions that tend to have some diffusion restriction. So diffusion in general, mild diffusion restriction does not help you one way or the other if you're considering hemangioma. It's only a robust diffusion restriction that is going to help you to say that, no, this is not hemangioma, this is indeed some kind of a malignancy or metastasis. So question in terms of your practice, if it's a 36-year-old female comes in for an MRI evaluation of the liver, a lesion seen during ultrasound examination for right upper quadrant pain, what do you do? Is it a liver MR with extracellular gadolinium chelate contrast agent? Is it a liver MRI with hepatobiliary contrast agents? Or is it a liver MRI with the hepatobiliary contrast agents and delayed images? So obviously, either the answer should be A or C. You should use an extracellular contrast agent or a hepatobiliary contrast agent. My personal preference when somebody comes in for the first time evaluation of liver lesion is to start with an extracellular gadolinium contrast agent. For the very reason I shared with you, if you go with the EOVist type of contrast, which are half of which is excreted into the biliary ductal system, you run yourself into a problem where the most common, the atypical hemangiomas, you may not be able to identify or diagnose them. So you got to be careful about that. So there's no right or wrong answer here. You could choose A or C, but just be aware of the pitfall if you're dealing with the hemangioma. Next case is a 36-year-old female with epigastric pain. Here is an ultrasound. You see an hypoechoic lesion in the left hemilobe, almost replacing the left hemiliver. You see that here, there is some flow in there. Here is a T2 weighted sequence. You see that, and we see some heterogeneous T2 signal intensity. T1 weighted pre-contrast. Here it is. And then in early arterial phase images, you can see the degree of arterial enhancement. And then in the subsequent post-contrast images, portal venous, and the equilibrium phase images, you see how the lesion is behaving. What is it the most likely diagnosis? Is it a hepatic adenoma, hemangioma, focal nodular hyperplasia, cholangiocarcinoma, or fibrolamellar hepatocellular carcinoma? I will show you one more image here, and that will be the 1 hour delayed. Here is a 1 hour delayed image. So look at this. Now, there is quite a bit of discussion on this case is that when you look at the equilibrium phase images, hey, the liver is washing out because you see that the periphery is brighter. You got to go back to the definition of what washout is. Washout is where that area that you're looking at becomes less intense than the background liver. So even though you have the peripheral areas that are brighter than this central area that looks like it's washing out, this central area is no different from the rest of the liver parenchyma. So as a matter of fact, this is not washing out. It's iso-intense to the liver parenchyma on delayed images. Once you recognize that, then you will make the diagnosis here. This is a focal nodular hyperplasia. So that's the key with the large areas of focal nodular hyperplasia with multiple fibrous septae. That's what this turned out to be. So if you look at a classic focal nodular hyperplasia, the lesion tends to be iso-intense to the liver parenchyma and T2 or slightly hyperintense. Similarly, in the T1, there could be a very minimal signal intensity difference between the T lesion and the background liver. Enhances in the RTL phase. It could equilibrate and then becomes iso-intense to the liver parenchyma. As you have seen in the earlier case, if you have enough of fibrous septae and if it is a larger lesion, it may fool you to believe the lesion is washing out. In reality, it's the fibrous septae that are taking up the contrast, and there is third spacing, and the background liver is what you need to compare it to. So this is a classic pattern of enhancement, a classic focal nodular hyperplasia. And then central scar. Don't expect central scar in all focal nodular hyperplasias. Even though we talked about central scar in the older literature, that was based on thicker slices and we were only seeing larger lesions. When you see the number of lesions that we see today with thin slice imaging with CT and MR, I would say more than 60 to 70% of focal nodular hyperplasias do not have a central scar. It is only the much smaller percentage of which they have a central scar. Okay. What about the patterns of enhancement on hepatobiliary phase imaging for focal nodular hyperplasia? There are 3 patterns of enhancement you have to keep in mind. One is the lesion can become completely iso-intense to the background. You see that in the pre-contrast images. You come to the post-contrast images, the lesion becomes iso-intense to the background and it disappears into the background liver parenchyma. That is indeed a pattern of enhancement for FNH. Number 2 is that there is a hyperintense rim. There is a hyperintense rim where the center is looking slightly hypointense, but the rim is hyperintense. And you can see that here, there's more of hyperintense rim. And the third is the background liver. Oh, then the entire lesion, there's a typo here. The entire lesion is picking up contrast in the background liver. Those are the 3 patterns of enhancement. So lesion iso-intense to the background liver, the hyperintense lesion is hyperintense to the background liver, and the third one is the peripheral rim. Where people get confused is this peripheral rim pattern of enhancement. As a matter of fact, this peripheral rim is actually a very characteristic feature for focal nodal hyperplasia. And just because the periphery is taking up the uptake on the hepatobiliary contrast agent, it should not throw you off, and you should be able to make the diagnosis. That is in contrast to a focal nodal fibrolamellar carcinoma, or could be a cholangiocarcinoma. You've seen a cholangiocarcinoma example before, where the periphery washes out or becomes hypointense in the delayed phase images. Here is a fibrolamellar carcinoma, large exophytic lesion coming off the inferior aspect of the liver, arterial enhancement. You see heterogeneous signal intensity on T2, very nicely enhances on the arterial phase. By the time you come to the portal venous phase, the lesion is washing out. There is only a sliver of normal liver parenchyma that you see on this image, but you can tell that this is becoming less intense in the background liver. And you have to, given the stellate pattern, you include fibrolamellar hepatocellular carcinoma. But even otherwise, even if you don't say fibrolamellar, you should say that this is a malignant lesion. This is not a benign lesion. Okay, I'm just checking the time here. So we're doing, okay. 61-year-old with jaundice and malaise. So what is the most likely diagnosis? Is it a hepatocellular carcinoma, metastasis, cholangiocarcinoma, or multifocal abscesses? Here is a haste, and you see that there is hyperintense T2 signal intensity. You see in diffusion, you see multiple additional satellite lesions are there. Here is the index lesion that you're seeing, but plus multiple additional satellite lesions. And then there's some diffusion restriction on the ADC map. You come on to the post-contrast images, you see this kind of areas with small peripheral enhancement. This is indeed multifocal abscesses in this patient. They can look like mass lesions. They can look like lesions with metastasis. So, but we need to recognize that if you have a diffusion, and abscess should always be in your consideration. Let me share a couple more examples with you. Here is a patient, the top set of images, T2 weighted, heterogeneous signal intensity on T2, T1 weighted images, and post-contrast. Notice that the central area, there are some areas of enhancement. This typically throws people off, saying that, hey, I have enhancement, so it has to be a solid mass lesion. You have to remember that in MR, they're extremely sensitive to picking up any tissue signal intensity. So what is an abscess? Abscess is necrosis or breakdown of the liver parenchyma, right? In the breakdown will never happen homogeneously. The breakdown will happen in areas or in pockets. So when you have these areas of viable hepatocytes, or they can show up as enhancing septations. So you should not exclude an abscess in that situation. You may not be able to just say, if you don't know the clinical history much, how the patient is behaving, you may not be able to say, yes, this is a definitive abscess, but you should also consider abscess in the appropriate situation, particularly patient with a white count elevation. Don't forget that our patients are commonly put on antibiotics. That could masquerade the symptoms, and you may not necessarily see the elevation of the white count as much. So keep that in the back of your mind. Here is another example. This lesion is bright on T2. Notice that there is a little bit of fluid adjacent to the liver. That is a sign of inflammation that is telling you that there is some adjacent fluid. If you look at that, and if you go on to the diffusion sequences, there is enhancement of the adjacent liver parenchyma, or diffusion restriction of the adjacent liver parenchyma, telling that there is some edema and there is some inflammatory response that's going on. ADC, the central area of diffusion restriction ADC. If you see it, it'll help you a lot. This is a classic hepatic abscess. Okay. This is a patient with a what looks like an abscess at the outset. But if you look carefully, there is a lot of hemorrhage on the T1 weighted images. You could say that this is all proteinaceous material and from a coagulate necrosis that is taking place. Absolutely, you could be that could be a possibility too. There's also thrombosis of the posterior segmental branch of the portal vein, and you see a transient hepatic intensity difference. And then again, it's a combination of these. Yes, you could have an abscess with the portal vein thrombosis. I would not fault anyone for including the abscess, but this turns out to be hepatocellular carcinoma with hemorrhage. So just as something to keep in mind. Switching gears a little bit, 51-year-old female with abdominal pain. Here you have a coronal haste, then T1 weighted pre-contrast, arterial phase image in the bottom left, and a delayed image here. And what is the most likely diagnosis? Is it a biliary cystadenoma? Is it a metastasis, or neuroendocrine tumor, or hepatic abscess? So in this case, if you see that this patient did not have any symptoms indicative of hepatic abscess in terms of clinically, we don't see any adjacent inflammatory response to the liver. There's no free fluid or anything else like that. There is a cystic lesion with some enhancement of the septations. There's not much of solid component to this, and it's a subcapsular location of the lesion. It's a female patient, so you got to think in terms of biliary cystadenoma. This patient also has gallstones, incidentally, but this is a biliary cystadenoma. The differentiation between biliary cystadenoma and cystadenocarcinoma, even though theoretically we talk about it, it's not always easy. So at least in our practice, when we talk about biliary cystadenoma, they take the patient to surgery if it's resectable and take it out, and the patient is amenable to surgery. The only way you can make a diagnosis of cystadenocarcinoma is if you see an interval change, you see a solid component to it, an enhancement, and even within or adjacent to the lesion, then you can entertain cystadenocarcinoma. Otherwise, it's kind of hard between a biliary cystadenoma and cystadenocarcinoma. Here is an example. Look at the T2 weighted sequence. You see a brightness on the T2, but when you come onto the post-contrast image right here, there's not only peripheral enhancement, but there is some central enhancement too, okay? And again, I'll show it to you on the transaxial post-contrast image. There's not only peripheral enhancement, but there's also central enhancement. So this, you could say, you know what, this could be an evolving abscess. I would take that in the differential as long as the patient has symptoms pointing towards abscess. Look for any secondary signs here. I don't see any edema. I don't see any inflammatory response surrounding this lesion. That should be a clue that this may not be an abscess. And this is a colorectal metastasis. This is indeed a mucinous metastasis to the liver. So be aware the mucinous metastasis can present and have different degrees of enhancement. Another case, a cystic appearing lesion. Why am I saying cystic here? So it looks like it is slightly hyperintense. It's not clearly as cystic as the gallbladder fluid. If you look at it in the transaxial image, there are some components that are showing bright, other components are not. When you go on to T1, you're seeing that the reason the lesion is not looking very fluidy bright is because on the T1 weighted sequences, there is some proteinaceous material or hemorrhage. That's why it is not looking fluidy bright. It's not looking like gallbladder. It is not looking dark as gallbladder. Post-contrast images, there's faint enhancements. This is somewhat similar to the biliary cystadenoma that we have seen, right? So not a problem. You could include biliary cystadenoma in the differential. It was in the differential here. And also, but something to keep in mind is that a cystic neuroendocrine tumor can have this kind of an appearance as well. And particularly when you start seeing T1 signal intensity changes within the cyst components, you got to think in terms of neuroendocrine tumor. So this is a cystic neuroendocrine tumor, but a biliary cystadenoma will have a very similar appearance. This is my favorite case. So if you look at the coronal haste sequence here, you see a T2 bright lesion. And if you look at the T1 weighted sequence on the axial images, you see it's not really fluidy bright. There is something hyperintense on the T1 sequence right here. Post-contrast, there's really absolutely no enhancement. Again, showing you the differential on the T2 weighted sequence. The key here is to recognize that it is a cystic lesion, no enhancement, and the location. The location is in segment 4A or 4B, and coming towards the porta hepatis or subcapsular in segment 4 or the middle liver, as we call it as. This is a very, very characteristic appearance for a ciliated hepatic foregut cyst. This is probably one of the most underdiagnosed entities. People don't think about this entity. This is a very benign entity. Very rarely they say in terms of malignancy. We have never really encountered malignancy in these patients. When we see this, we do call the ciliated hepatic foregut cyst. The patient is symptomatic because of capsular stretching. They may get surgery, or they typically get observed. But your characteristic appearance is this kind of a T2 hyperintense, some proteinaceous material, no septations in that, no enhancement, segment 4A, 4B, then you're dealing with ciliated foregut duct cyst. They're typically under less than 3 centimeters in size. Let's look at this here. The 45-year-old male with right upper quadrant pain and jaundice. All right. So what is the most likely diagnosis? Cholangiocarcinoma, Mrcp syndrome, inflammatory pseudotumor, or metastasis. You have an Mrcp sequence that shows the biliary ductal dilatation. You have multiple gallstones here, and you see the gallstones right there. You have the extrahepatic bile duct. You see the narrowing of the bile duct in the common hepatic portion of it. And here you see the cystic duct. If you start looking carefully, you see the narrowing of the common hepatic duct, but you see there's a crescent of filling defect in the cystic duct itself. And that's what you're seeing right here with the rim of enhancement. So this is indeed a Mrcp syndrome. It is picking up that there is a stone in the cystic duct will help you make the diagnosis. The inflammatory response from the stone and the inflammation will almost always cause obstruction to the common hepatic duct. So this is a case of Mrcp syndrome. Another example, here you see Mrcp images, biliary ductal dilatation. You come down, there is narrowing of the right and the left hepatic ducts and the common hepatic duct. If you go on to the post-contrast images, you see some peripheral, some enhancement along the course of the bile ducts. So you're seeing some enhancement go there and come down on that. This is a cholangiocarcinoma. Different example. You see that there is this is of course an ERCP image. You see a very tight narrowing of the common hepatic duct, and there is a concentric thickening. And then here you see the concentric thickening. And if you notice carefully, this concentricity is slightly eccentric on one side. That is very, very typical for cholangiocarcinoma. It is not just a completely round. You tend to have a soft tissue component more to one side. So make an observation, pay attention to it, and you'll see that. And that is very typical for cholangio. This is another example of cholangiocarcinoma. A point to note about cholangiocarcinoma, is that you will never see a cholangiocarcinoma without biliary ductal dilatation, okay? So anytime you encounter a biliary ductal stricturing or stenosis or the soft tissue component, but you don't have a biliary ductal dilatation, you got to take a step back and say, is it really a cholangiocarcinoma? A different case, you see mild biliary ductal dilatation. This patient has some gallstones here, and then you see there is a soft tissue component around the common hepatic duct. I'm showing you the soft tissue component of the transaxial image. There's a soft tissue component right there, and there's a little bit of an enhancement. This looks like cholangiocarcinoma. You have to call cholangiocarcinoma. One thing that did catch us as atypical is the very smooth nature of the soft tissue and the fact that the degree of soft tissue component and the degree of biliary ductal dilatation were not in sync. This ended up being a lymphoma involving the bile duct. Okay, so MRCP image, you see the biliary ductal obstruction. You look at the pre-contrast weighted images. That's right here. Here is the post-contrast, early post-contrast image. This is the late post-contrast image. The history here is, well, I gave you the diagnosis. This patient has had a breast cancer in the past. She had a breast cancer 10 years ago, and she was otherwise asymptomatic. If you look at the PTC image or the cholangiogram, you can see the stricturing of the bile duct. Here is the point. If you see a lesion that looks like cholangiocarcinoma, this is for all practical purposes looking like cholangiocarcinoma, right? Even in the PTC or the MRCP images. But the patient has history of breast cancer. Even if it is 10 or 15 years remote, you got to think in terms of breast cancer metastasis. Even very late, they will present, and if they have a history of breast cancer primary in the past, breast cancer metastasis is the most likely diagnosis. They will simulate cholangiocarcinoma. So that's the main point here with regards to the breast cancer metastasis. Okay. Here's an 80-year-old woman with right upper quadrant pain. Let's analyze these images. Here is haste in the axial plane. You see there is a lesion, high intermediate Brighton T2 weighted sequence. You look at on the coronal sequences, you see that it has you get a sense that, hey, what is happening to the bile ducts? The bile ducts are coming in, and there's an obstruction to the bile ducts. There's biliary ductal dilatation. Is this within the bile duct itself is the question that comes up. Look at the diffusion sequences. There is some diffusion restriction, and on the ADC map, you do some diffusion restriction right there. Post-contrast images, this is a pre-contrast. Notice that this is an early post-contrast rim of enhancement. You come on later on, there's progressive enhancement right there. And now on the post-contrast images, it is very clear that this is indeed sitting within the bile ducts. So this is intraductal papillary neoplasm of the bile ducts, or IPNB. And another close-up of those two images, the coronal haste and the post-contrast sequence right here. You see that there's a filling defect within the bile ducts. Typically, when you see that, it's an intraductal papillary neoplasm of the bile ducts. It can be low grade to high grade. There's no way we can differentiate an MR, whether it's a low grade or high grade. In general, the lesser the diffusion, it could be low grade, but that is not enough of an indicator for us to tell that it's a benign or not. So these patients would go for a biopsy, ERCP, and or a resection, depending on what it is. This entity is quite common more so in Asia than in the West, but we do see enough of cases. The risk factors are recurrent pyogenic cholangitis, or patients with PSC or choledochal cysts. So this is the intraductal papillary lesion within the bile ducts, something to keep in mind. Now, in addition to a primary intraductal papillary neoplasm, this is similar to an intraductal papillary mucinous neoplasm of the pancreas, but it's happening in the bile ducts. In addition to this, when you have an intraductal filling defect, do not forget your metastasis. Colorectal metastasis can do that. And colorectal metastasis and or renal cell carcinoma metastasis can do that. Mostly renal cell is rare, but primarily it's colorectal metastasis that would go into the bile duct, and they can have a deposit along the wall of the bile duct and simulating intraductal filling defect. Here's an example of a different case. You're seeing the biliary ductal dilatation. There are multiple filling defects within the bile ducts. And in the post-contrast images, you are seeing the periductal enhancement. Right off the bat, you know that there are filling defects within the bile duct. There's periductal enhancement, and there is a component of cholangitis. I'm not showing you the exact slice here. There was no enhancement whatsoever of these filling defects. I don't have the subtraction images. And so these components are not enhancing. So it's not a papillary neoplasm of the bile duct. So this is something that is causing cholangitis. This patient, as a matter of fact, has recurrent pyogenic cholangitis. An ultrasound image showing you the hypoechoic area in the region of the porta hepatis. There is intrahepatic biliary ductal dilatation. And you see, for all practical purposes, if somebody shows this to me again tomorrow, I'll say that I'm most likely dealing with a cholangiocarcinoma. This is not a cholangiocarcinoma. This turns out to be an inflammatory pseudotumor that can mimic cholangiocarcinoma. The reason to point this out is not that you have to make a diagnosis, but you will come across inflammatory pseudotumors at times, and they typically tend to occur by the porta hepatis. And the only thing that may clue you that this may not be a cholangiocarcinoma is a discordant clinical picture. The patient comes in out of nowhere and has this, and there's no weight loss or any other symptoms, but majority of the time it's not possible. But don't be surprised if you get a diagnosis and it says, hey, it's an inflammatory pseudotumor. This is not a cholangiocarcinoma, because they can simulate cholangiocarcinoma. If patients who have had serial MR images for one reason or the other, and you suddenly see this, and that's something that has helped us saying that, hey, this could be an inflammatory pseudotumor. So they would do a short course of steroids if you suspect inflammatory pseudotumor, so that then we can see what happens. But other than that, it would not be possible for us to differentiate between the two. Next case, I do think it's the last case. Here is an MR. The history here on this patient is that he's a 70-year-old male, status post liver transplant with elevated liver function test. Let's analyze this. So you see that there is a space-occupying lesion, mildly hyperintense on T2. There is some biliary ductal dilatation that you see right here. You go on to the diffusion. There is some diffusion restriction that you're seeing centrally. This is a fat-only image, and then water-suppressed fat-only image. There's no fat in that lesion. You come on to the post-contrast images. You see earlier on, there is a little bit of transient hepatic intensity difference surrounding the lesion, and the lesion slowly starts enhancing over time. And this patient, the key here is that this patient is post-transplant, right? And then could this be a recurrent lesion? This is the hepatocellular carcinoma recurrent. It's possible. It's not the classic hepatocellular carcinoma appearance in terms of there's no arterial enhancement and washout. It is actually slowly enhancing and progressively filling with contrast. Yes, there is diffusion restriction to the lesion, and there is some space occupation or mass effect of this lesion. How do you know this patient is post-transplant? If you look at the inferior vena cava right here, you're seeing the dephasing artifact around the IVC. That's very, very characteristic appearance for a patient who had transplant. It's not the surgical staples. It is just the fact that they have sutured the IVC to the donor liver to the recipient IVC, you will see dephasing artifacts and gradient echo sequences. So that is a telltale that the patient had liver transplant. The only other time you see the dephasing artifact would be if somebody would have had a cardiac resection where they mobilize the entire liver, but this, you see the cardiac is still there. So the presence of the history of post-transplant is going to lead you more towards, and not a characteristic feature for hepatocellular carcinoma. You should think in terms of post-transplant lymphoproliferative disorders. As we do more and more transplants, as we keep our patients longer, we see PTLD, or post-transplant lymphoproliferative disorder, happening. And liver is actually one of the common sites that we see PTLD. You could have lymph nodes or a group of lymph nodes anywhere in the abdomen or pelvis. And it's a higher incidence in patients who had pancreas, heart, and lung transplant than the liver transplant for the kind of immunosuppressive treatment they use. But you will see with post-liver transplant as well. And you're talking about wanting to do more liver transplants, so I'm sure you'll encounter this. The etiology here is believed to be immunosuppression with associated viral infection, but I don't think we really know. And you can see between 1 to 7 years post-transplant, and we have seen outside of 7 years as well, but typically that's the time frame that you see PTLD. So I know this is a mix of cases I kind of took you through. We did not cover hepatic adenomas or hepatocellular carcinomas, which are a topic of discussion by themselves, and have reviewed the characteristic features of some of the commonly encountered benign liver lesions and their mimics and the malignant counterparts. We looked at those. As I mentioned earlier on, understanding the characteristic features and variations is the key for a successful prospective diagnosis of the lesions. As a body imager, as an MR imager, our role does not stop in looking and saying that there is a lesion. Our role is that we take that lesion and further characterize it and help triage our clinical colleagues so that we avoid unnecessary biopsies, unnecessary interventions, and give a definitive diagnosis as much as possible. And we should do our very best to diagnose every benign lesion that we know of, and particularly hemangiomas. We should not misdiagnose those hemangiomas. So thank you very much for all of your attention and taking the time and joining this. And thanks to Dr. Kavita and Dr. Vijay Bhaskar and the team for giving me the opportunity. And it is indeed a pleasure and an honor to be talking to you all. I'm happy to take any questions and answer any questions that you may have. Thank you.
Thank you very much, Vamsi. That was a very enlightening lecture about non-HCC lesions. Like I told you before, everything is HCC or otherwise. So this is what is expected to be learned by the radiologists who are reporting livers regularly. So that was a very nice presentation, and it was very systematic, practical, algorithmic approach to the students. I hope whoever goes through this article lecture will be benefited in their future reporting patterns.
Thank you.
I request whoever is there in the audience to send their questions through chat box. In the meantime, I would want to ask Vamsi a couple of my own queries. One was, you said you are doing a multi-echo GRE sequence for iron quantification in the liver.
Yeah.
So I have a doubt here. We have got R2 star technique with standard software on the workstation, either Philips or GE or Siemens, and then a multi-echo GRE sequence. Now, if I were to ask you that in a given patient, would you do iron quantification from a R2 star derived from a multi-echo GRE sequence, or an R2 star dedicated study with using multiple echoes on a workstation?
See, if you have an R2 star derived sequence and you have my experience has been, before even R2 star become prevalent, we started using multi-echo GRE sequence and quantifying it. So I am kind of biased towards it because it's a very easy technique and we do that. But if you have a robust enough R2 star and you can have the multi-echo that you could do, you guys could quantify it. That is a better way of doing it. If you do the R2 star values, that's always a better way. I was primarily saying that from a multi-echo GRE sequence, from a visual perspective, we can all, we don't want to sit down and quantify the iron all the time. from a visual perspective, you should be able to make the diagnosis that this patient has iron. But if you have AutoStart, I will always prefer an AutoStart sequence over a multi-echo GRE.
Thank you. The issue why I brought up this question was in severe iron overload, where you can't go TE below 1.5. You can't go below that. It is prone to truncation artifacts on a AutoStart sequence, because you can't go below that. You can't go TE below a level.
Yeah,
you're prone to develop truncation artifacts. So what we are doing is, in such cases where there are truncation artifacts are expected, we are trying to take it from R2 star, draw ROIs, calculate the R2 star, T2 star, and give the iron quantification. Yeah. But as long as it's mild and moderate iron overload, R2 star is good enough. This is our experience.
Yes.
So that is what. Then one more doubt. I think not many people are asking. We'll see. One more doubt. Do you have any experience with this intravoxel incoherent motion of DWI and texture analysis of liver, anything of that sort, T1 mapping of liver?
We're just doing that with the T1 mapping. I haven't really seen how to practically apply that on a day-to-day basis yet.
Okay.
But we are just acquire those sequences. They're coming in with our scanners now, and we're acquiring it. I couldn't comment much in terms of how to. One of the key things whenever you apply these techniques to various patients is to make them easy and it should be consistent and reproducible in terms of interpretation. I don't think we're there yet. So I think we need a little bit more understanding of how these sequences behave and what is it that we are deriving out of this to help make a diagnosis.
That's nice. Just to inform you that we don't have EOS in India. Not permitted.
Oh, you don't? Okay.
Not permitted. We only use multi-hands.
So I actually am a big proponent of multi-hands. If you really ask me, we have never missed a diagnosis of focal nodal hyperplasia by using multi-hands. So multi-hands is actually a very, very solid contrast agent. Even though it's only 5 to 10% of excretion in the biliary ductal system, it will never sway you in other way. Yes. As a matter of fact, we have had false positive diagnosis or false negative diagnosis with EOVIST, not only for the hemangioma, but even you can have a well-differentiated hepatocellular carcinoma that would take up some contrast with EOVIST, and we have had difficulty, but we don't have those issues with multi-hands. So my choice, as a matter of fact, is multi-hands as a contrast agent and get 1 hour delayed. But we see a lot of our liver practices in America because of the hepatobiliary contrast agent, they use EOVIST. So then as a result, I want to give them that word of caution of the EOVIST.
One last thought from my side, Vamsi. How do you differentiate intrahepatic mass-forming cholangiocarcinoma with T2 hypointense central signal, that is mucin, versus a mucin-producing CA colon cancer metastasis?
So you're saying that cholangiocarcinoma that has central mucin?
Yes.
So
or fibrosis?
Yeah. So fibrosis is okay. See, mucin, we have thick mucin and thin mucin, and we have never been really good in terms of definitively making a diagnosis that this is indeed mucin. It's only in retrospect we say that, yeah, there is mucin. So for example, if you take intraductal papillary mucinous neoplasm of the pancreas, you never can say that this is a mucin producing or not. We go by the anatomy and the morphology and say that this is an IPMN of the pancreas. So we are not at all good with mucin. We take the indirectly, we can see. Even if you take ovarian lesions, only a certain percentage of the time for the mucinous neoplasm, we may see signal intensity changes. And that is because of the nature of mucin and this thick mucin versus thin mucin, and you never will be able to make a diagnosis. So from a cholangiocarcinoma, if the pattern of enhancement is different than a mucinous neoplasm, it depends on where the lesion is located. If you say, for example, cholangiocarcinomas tend to like the middle, if they're intraparenchymal, they tend to be in the segment 4, segment 8 region. They try to go towards the IVC. For some reason, they like the IVC and they kind of tether the IVC or the pucker the IVC. So it depends on where the lesion is, but not always it's possible. So to your point, if you're saying that I cannot differentiate at all times if it's a mucinous colon cancer metastasis for the cholangiocarcinoma, I would agree with you. It's not always possible. But the key thing there would be for us not to include a benign lesion in the differential or mistake a benign lesion. That's the point I was trying to drive across from between differentiating these lesions.
Yeah, one last thing. PET CT, role of PET CT in hepatic malignancy.
Yeah, we use it quite a bit, PET CT here. There's one area PET CT fails, especially the standard agents fail, is with regards to hepatocellular carcinoma and a cirrhotic liver. Aside from that, PET CT does work very well for the kind of lesions that we see, for example, hepatic lymphomas, neuroendocrine tumors, or any kind of atypical metastasis, cholangiocarcinomas. We have, PET CT is helpful in those staging and workup. The only area I would say in general, trying to simplify things, is with regards to hepatocellular carcinoma, where you need to be careful because PET CT does not necessarily help you there. And of course, you have Dr. Kavita. She can tell you more about PET CT than I could. But that's, at least in general, that's the experience with the liver focal lesion characterization.
We get queries stating that PET CT is negative in mucin-producing colon cancer, metastasis in liver, breast metastasis in liver. Please do MRI. And we have the experience that MRI is picking up much more lesions than what PET CT SUV values are not very great. So that is why.
But you will, if you look at the PET CT in that particular context, you will see some rim of uptake at the periphery. And again, Kavita, you can say that in those, you will have a central hypointensity and you don't have SUV values there. But in that mucinous metastasis, you will have a hint of that this could be a mucinous metastasis based on the peripheral, if there's a peripheral uptake. Centrally, of course, you won't have much of an uptake at all. And in that situation, yes, MR could be better. Kavita, your comment on that?
Uptake. It's low uptake, rather no uptake, especially because we have CT there to characterize the lesion also. And as you rightly said, it's low uptake, especially in the periphery, not in the center. That's characteristic of mucin producing metastasis. And regarding hepatocellular carcinoma, you have fully differentiated, intermediate differentiated, and poorly differentiated, well differentiated, intermediate, and poorly. Well differentiated HCC, yes, FDG PET doesn't have a role. But poorly differentiated HCC, definitely FDG has a role. So it depends upon the histopathology of HCC, where it is used for either staging or restaging or treatment response and all this.
Bhaskar, there's one in the chat.
Differentiate between hemangioma and hyperintense metastasis.
Right. So here, the hemangioma and hyperintense metastasis, the hyperintense metastasis, I'm taking that hyperintense, meaning that hyperintense on T2. And then, so the key thing here is the enhancement pattern and presence or absence of washout. Okay. As I was telling you with hemangiomas, whatever the area that picks up, even if the entire lesion doesn't enhance over time, if it's an atypical hemangioma, the area that picks up contrast on your arterial phase or portal venous phase, that area can become iso-intense to the background, but should never become less intense to the background liver parenchyma. Even if you see portions of the area becoming less intense to the background liver parenchyma, you're dealing with metastasis or another primary, or I don't know, something else. So the paying attention to the pattern of enhancement and the absence of washout is going to be the key for differentiating between hemangioma and a metastasis.
Any role for diffusion weighted imaging in that?
Yes, again, absolutely, there's diffusion weighted imaging, but remember with the diffusion weighted, see, none of these techniques are absolutely perfect, right? So even when you use the diffusion weighted imaging, you lose, if the hyperintense metastasis is more cystic or mucinous, as we are having the conversation, then diffusion won't help you because it'll not show diffusion restriction, because where diffusion restriction typically parallels what we see on PET, right? So if you don't have much of a diffusion restriction, it means it's going to be not have much of an uptake in PET. You may see peripheral diffusion restriction. If you see it, then that's great. That'll help you that there's a peripheral diffusion restriction. If you don't see the diffusion restriction, it may be, sorry, Kavita, go ahead.
It's very simple on PET CT to differentiate between hemangioma and metastasis.
That's so. That's right. So then the diffusion restriction, just be careful that if you are thinking in terms of an atypical lesion, that you may have slight overlap between diffusion restriction and you may see some element of minimal diffusion restriction hemangiomas. As long as you have that in the back of your mind, you should be able to differentiate them out. Another question I see that is HCC is MRI better than CT? I truly believe that if you look at HCC for a diseased liver or even otherwise, but in general, a diseased liver with any kind of a viral infections or steatohepatitis, autoimmune disease and whatnot, MRI is indeed better than CT for hepatocellular carcinomas. We tend to see smaller lesions. We can do a much better definitive characterization than CT. For the larger lesions, you will not have much of a difference between CT and MR. You should be able to separate them out. But the architecture of the lesion itself, or the phenotype of the lesion itself is much better characterized on MR than on CT.
As a radiologist, you are more satisfied reporting MRI HCC than CT because you've got so many parameters.
Correct. We are more satisfied, more definitive with an MRI than CT. Are there instances we have to use CT? MR is also not perfect. Are there instances we have to use it? Absolutely. And we will go use that. But as a default for we have a large liver transplant program. So every day we have at least 25 to 30 liver MRs that we do for these patients. So that's a minimum number. And then, so it's by default, it is MR. And it's only when MR doesn't answer or MR needs help, or the patient cannot get an MRI for one of the other reasons, is we go on to CT. We are doing a lot of, we have actually a day-long service where we do MRI in patients with pacemakers and lead implanted. So that is actually an area that is picking up. Conditional plate, the pacemakers, MRI compatible pacemakers. So we're seeing more and more of those being placed. And we work with electrophysiology team who come in and monitor those patients and our MR physicists, and we do MR on those patients.
Very nice.
So metastasis versus HCC. Yes, if the patient has a non-diseased liver, you may not be able to at times differentiate HCC versus metastasis. In a diseased liver with a cirrhotic liver, absolutely, you can almost always differentiate that between hepatocellular carcinoma and metastasis. Keep in mind a couple things. The HCC, you can have single lesion or multiple lesions. HCC can at times have a dominant lesion with multiple satellite lesions. This pattern of dominant lesion with multiple satellite lesions can be seen with HCC. You can see with cholangio, but you can see with colorectal metastasis too. So you have to take it in the context of what is the patient presenting with, what is the background information I have, as you interpret these studies. But the short answer is, for the most of the time, you can differentiate the HCC versus metastasis. But if you're asking the question for a single lesion, HCC versus metastasis, when the liver is not diseased, you have to keep in mind from a pathology perspective, HCC is an adenocarcinoma, so majority of metastasis are adenocarcinomas. So you may not have, both are going to behave malignant. So that is the overlap that you'll have, unless you have a diseased liver, unless you have something else pointing out to it, or slight variability in terms of how the lesion is behaving. If your question is that, can a metastasis adenocarcinoma look like HCC? The answer is yes. But the characteristic appearance for HCC is arterial enhancement intensely, and then it washes out right away in the portal venous or equilibrium phases. Whereas for adenocarcinoma metastasis, they enhance, but then instead of completely washing out, they could, but instead of completely washing out, you see the progressive central filling with periphery washing out more. That is more typical for adenocarcinoma metastasis. Is there overlap? Absolutely, there's an overlap.
Your experience with PET MRI, Vamsi?
So yes, Kavita, as a matter of fact, I was involved in setting up the first PET MR